Good evening, everybody, and welcome to the BASH webinar of the 2021 series. This is the 6th webinar of the series. My name is Fayaz Ahmed, and I am a neurologist in the northeast of England. And I'm also the educational officer for the British Association for the Study of Headache. I'm very grateful for BASH Council, our speakers, and all the attendees that have made these webinars really successful. I'm also grateful to all our sponsors. And at this point, let me share one of my slides. So we have an unrestricted educational grant from Allergan, Teva, Lilly, Lundbeck, and Sun Pharma to make these educational events possible. As you can see that the webinars are approved for 2 CME points per webinar. So if you attend all the 12 webinars of 2021, you got 24 external CME. And the program is available on the BASH YouTube channel after a few weeks of being live on the BASH webinar platform. So today the topic is, let me just get the slide. So today's topic is migraine in women. And to talk about migraine in women, you can't find better people than 3 lovely women, Anne McGregor, SHAZIA Afridi, and Manuela Fontebasso. Anne is currently in New Zealand, isolating from the COVID restrictions. So she wouldn't be present live in this webinar, but we would have her presentation recorded. But we would have live presentation from Shazia and Manuela. The next webinar, which would be on the 28th of July, would be on CSF dynamics and headaches. So we would be discussing about IIH as well as the low CSF pressure, and we would have Alex Sinclair, Paul Doman, and Ben Weckerly. I'm sorry that the one name is written twice. So please do come. As you know that the registrations are open straight after the webinar of the previous month. So do come and join us next month as well. So I would start the presentation of our first speaker, Anne McGregor. Anne McGregor, I have known her for nearly 25 years. She's been a specialist in headache and women's health. She's a professor in London and currently practices headache in Harley Street. She's got 30 years of experience dealing with headache disorders and has a portfolio of research and publication, and has been affiliated for many years in the British Association for the Study of Headache and the International Headache Society. So she's going to talk about the women's life cycle and migraine. And I would just put her presentation. Are you able to hear?
No.
You're not, right. Let me just...
I can't hear either, Fires.
Okay, no problem. Let me just see where the problem is.
After, in later life, it...
Okay, sorry about that. I'll just start it from the beginning.
I'm absolutely delighted to participate in this BASH webinar on migraine in women. My name's Anne McGregor, and I'm going to be talking about the life cycle of migraine in women. So looking at the clinical perspective of what happens to migraine and how it changes over a woman's life. I'm sure you'll already be aware that the prevalence of migraine during the reproductive years is about 3 times greater in women than in men. And we see this particular rise around the time of puberty in both sexes, but much greater in women. And it stays that way to be about 3 times greater during the reproductive years, where after, in later life, it declines in both sexes. Now, we'll come back to that a little bit later, but to start off with, let's just start looking at how migraine changes across a woman's lifetime. So we're going to start with Natalie. Now, Natalie is just approaching puberty, and as she approaches puberty, her risk of having migraine without aura quite substantially increases with the change in hormones. Now, she's also at a greater risk of migraine with aura, not to the same extent as migraine without aura, but there's still a flurry of increased incidence associated with puberty. Now, as Natalie grows older, she grows into a lovely young teenager, but the only problem is that she starts getting really bad headaches. Now, they're not too long lasting, but they do interfere with her studies a little bit. But fortunately, she can take some painkillers and the headaches resolved. So she's got pretty good control over her attacks. Now, as Natalie gets a little bit older, she's taken quite a shine to one of the boys at school. She's very heterosexual, and they go out dating. And she falls in love. The only problem is she very quickly realizes that she's going to need some contraception, as she doesn't want to start a family at this stage. So she thinks about the best methods of contraception. She has a chat at her local sexual health clinic and visits her GP. And she decides, because she's got a bit of troublesome period problems, to start on combined hormonal contraception, so the estrogen progestogen contraceptive pill. Now she starts taking that, but during the 7-day hormone-free interval, so 21 days of pill taking followed by a 7-day break, she starts getting an increase in headaches, as seen by her daily headache score. When she's taking it on the 21/7 regime. So she goes back to her GP because she's getting a bit fed up with getting these headaches, and her GP advises her that the much better way to take the combined pill, irrespective of her headaches, is to take it every single day without a break. So that's exactly what Natalie does, and she finds that her headaches markedly improve and she's feeling a lot better. Sadly, for Natalie, she has her first migraine attack with aura. So she goes back to the GP because she's not entirely sure what it is. The GP makes the correct diagnosis and tells her that she has to stop the contraceptive pill. Now, unfortunately, Natalie didn't get to her contraception fast enough, and she becomes pregnant with her first child. Now, during pregnancy, her migraine without aura got better, as is typically the case. So migraine without aura, about 70% of women experience improvement or complete disappearance of their migraine without aura attacks. That's not the same for migraine with aura, where only about 40% of women report an improvement during pregnancy. Now, as Natalie gets older, she's had a couple of children now, and she's noticing an increasing link between migraine and her menstrual periods. So if we look at her diary, we see that the there's squares for each day of the calendar year, and a cross represents a migraine attack, a stroke, just a headache, and a circle is each day of menstruation. So she's having regular menstrual periods, but she's having these longer migraine attacks associated with her menstrual periods. And she reports to you that these menstrual attacks are much less responsive to treatment. She needs to take more treatment. She's got many more associated symptoms. She feels much more nauseous, much more sensitive to light. The headache is much more severe. It can go on 4 or 5 days, and she feels extremely disabled by these attacks. She hasn't really been able to find effective treatment because her GP hasn't attended the BASH webinar, so doesn't really know how to manage it. So she struggles on through and is gradually approaching perimenopause. Now, what happens is that her migraine attacks are becoming a little bit more erratic. Her periods are also becoming a little bit more erratic, and she's also beginning to get more frequent hot flushes and night sweats across the whole menstrual cycle. And you'll see from this slide that migraine predicts more frequent vasomotor symptoms, particularly in the late menopause, both for hot flushes and also we see for night sweats as well. So as if the migraine wasn't bad enough, women with migraine also are more likely to have to be faced by worse vasomotor symptoms, flushes and sweats. Now, what happens as she goes through the menopause? Well, fortunately, most women will report an improvement and a reduction in the frequency of migraine attacks as they go through the menopause. Now, the prevalence improves with the time since the last menstrual period, and that essentially is mirroring the decline in ovarian function. And it also mirrors what we see with the duration of hot flushes after menopause. So you need to be aware that the menopause isn't an immediate event. So while we define the menopause medically as being a woman's last menstrual period, there is continuing ovarian activity for several years after that last menstrual period, and that is shown by the continuing hot flushes. So they only really resolve as ovarian activity starts to settle down. Let's go back at looking at this prevalence of migraine and why there is this bimodal distribution at the two extremes of reproductive life. Now, if we look at the rate of change of migraine prevalence over age continuum in females and women, we see that there is an accelerating rate of change with adolescence and a further acceleration of rate of change of prevalence associated with perimenopause. And interestingly, this mirrors what we see in the fluctuating estrogen levels. So at puberty, we see quite marked fluctuations in estrogen as a woman's body is gearing up to reproductive activity and ovulation. And similarly, as the ovaries are beginning to decline, again, we can see quite marked fluctuations in estrogen activity. So it's actually a myth to say that from menopause or in perimenopause, the estrogen levels decline, because actually they can sometimes spike quite high. Now, looking at the effects of estrogen on migraine, there are two main hormonal events that we see that estrogen participates in with respect to migraine. One of these is estrogen withdrawal. So this is the decline of estrogen after a period of a sustained, stable level of estrogen present in the body. And we see estrogen withdrawal with menstrual migraine. we see it during the hormone-free interval of combined hormonal contraception, and we also see that with the dramatic drop in estrogen that occurs postpartum. So if we just look at a schematic of looking at the natural cycle, with the pink being the levels of estrogen rising at the time of ovulation, then a drop rising again to a more sustained, stable level during the luteal phase, followed by a fall as we approach the next menstrual cycle. And similarly, in the hormone-free interval of combined hormonal contraception, then the estrogen levels of ethinyl estradiol rise quite quickly after a woman starts her new pill pack, assuming she's not taking it continuously. And then there is a drop that takes about 3 days into the hormone-free interval. And in both these situations, we see that the fall in the level of estrogen is associated with increased risk of migraine. Now, I'm not going to go into all the detail regarding the other hormones, except to say that estrogen withdrawal is a trigger for migraine independent of what's happening with changes in progesterone, and indeed even independent of ovulation. And what we see is that it tends to be migraine with aura that is triggered or associated with estrogen withdrawal. Now, if we look across the menstrual cycle, we see an inverse relationship between estrogen and migraine. So if you look at the purple, this is the percentage of days reported with migraine, and day 1 is the first day of menstruation. And here we're seeing this peak or increase in migraine incidence associated with the perimenstrual time, starting just a few days before the onset of menstruation and continuing just into the first few days of bleeding. Now, if we look at falling estrogen levels, it's triggering migraine, as we discussed in the previous slide. But it's important to also note that it appears that rising estrogen levels can actually protect against migraine. And you'll see that there is a reduction in the percentage days reported with migraine at times of estrogen rise. Now, estrogen and progesterone levels in pregnancy, we see this gradual rise to quite high levels of both estrogen and progesterone. And again, rising levels protect against migraine, which may well explain why we see this improvement in migraine, particularly migraine without aura, during pregnancy. Now, immediately postpartum, there is this sudden drop in estrogen levels, and this is associated with increased risk of migraine immediately postpartum. In contrast, high estrogen states can actually be associated with migraine aura. So we've got a complete difference of the effects of estrogen state on the 2 different types of migraine. Now, we see this in pregnancy, so that migraine can occur for the first time associated with or migraine with aura can occur for the first time in a woman as she becomes pregnant. We can also see it when women start combined hormonal contraception, they develop migraine aura for the first time, as the case with Natalie. And oral HRT in particular, particularly the higher dose HRT, which we should really be avoiding anyway for women, can also be associated with incidence of migraine. Now, just going back to what we were mentioning before about high estrogen states and migraine aura, and about how we saw this rise in both migraine without aura and migraine with aura at menarche. And that is probably because we're seeing these spiking high fluctuating levels, which can be just enough in some situations to trigger off aura, as well as the more typical migraine without aura. Similarly, in perimenopause, another time where migraine with aura can often become more prevalent, again, likely to be due to these spiking high levels of estrogen. So let's just summarize where we've got to with our lifetime of a woman. So puberty, we see increased incidence of both migraine with and without aura. And estrogen-containing contraception, we see increased risk of migraine without aura during the hormone-free interval. But we also see an increased risk of migraine with aura during hormone treatment. I think I'm seeing double vision with the obs there. I must be getting migraine aura myself. In pregnancy, we see a reduced risk of migraine without aura and an increased risk of migraine with aura. So we've seen the stable levels, the rising levels can protect against migraine without aura, but high levels are triggering potentially migraine with aura in a susceptible individual. And finally, with perimenopause, we see an increased risk of menstrual migraine without aura and an increased risk of migraine with aura, both of which tend to resolve post-menopause. So I hope you found this journey through a woman's migraine lifetime helpful to your understanding of how things can change as a woman ages. And you are now going to be able to manage these hormonal changes, provided that you listen to Dr. Afridi's talk after this. So thank you very much for your attention.
Well, thank you very much, Anne. So nice of you to record your presentation, and we wish good luck for the speedy recovery of your mum in New Zealand, where you are currently visiting, from all of us in BASH. We'll take the questions at the end of the webinar. So let me come to our second presentation, as Anne mentioned, SHAZIA Afridi. She's a consultant neurologist in Guy's and St. Thomas's Hospital. She has done her PhD in neuroimaging. She has written a lot about women and migraine, and her particular publication in Practical Neurology has been cited by many people. And she's recently, fairly recently, maybe just last week, published a paper of headache admissions in A&E in the UK, in cephalalgia. So if you have a chance to read that paper, it's really a good paper. I have just quickly whizzed through it, but I think it's got a lot of information. So Shazia is going to talk about menarche to menopause and see how you manage migraine in different phases of women's life.
Thank you very much, Fayaz. Thanks for inviting me to this wonderful series of webinars that BASH have set up. I'm just going to set my screen. Can you see that?
Absolutely.
They're all working on, excellent. So, as Fayaz mentioned, I'm a neurologist in London, and I have an interest in migraine in women. I'm going to talk to you today about management mainly of migraine in different phases of a woman's life. You've heard a little bit already about the importance of estrogen, so my talk's really going to focus on management. But these are my disclosures. And I'm planning to talk about menstrual migraine, how to manage migraine during pregnancy and lactation, and then a little bit around menopause. So this, I think, is a really lovely diagram depicting how hormones, in particular estrogen, as you've heard in Anne's wonderful talk, influence migraine frequency at different phases of a woman's life. So this first section here is the menstrual cycle, and the grey peaks signify increase in frequency of migraine. So you've got this grey peak here around menstruation. You've got a peak here after a woman's given birth in the postpartum period, and this perimenopausal peak. And as Anne already mentioned, the most important hormone in migraine is estrogen, which is depicted in dark blue in this diagram. So this correlates with the decline in estrogen in most of these cases. I'll talk a little bit about that, but I won't go into too much detail, as you've already heard about that from Anne. So starting with menstrual migraine is very common, and many of you, when you see your patients in clinic, you ask them about their migraine triggers, and of course they have triggers like sleep disturbance, etc. Most women will admit to having a menstrual trigger, so they'll say, well, their migraines are worse around the time of their period. And there are a smaller proportion of women that only exclusively have menstrual migraine. That's called pure menstrual migraine. But the peak time for onset is usually about 2 days before the onset of menstruation. And it's really to do with this drop in estrogen, as Anne mentioned. So if you look here in this chart, that shows you the dark blue increase around ovulation, drops a little bit then, it increases again, then drops finally just before menses. And this graph is taken from quite a recent paper, which also looks at oxytocin, which I think is quite interesting, because if you look at oxytocin in yellow, this also mirrors the estrogen increase and drop just before menstruation. And there's a lot of interaction between estrogen and oxytocin. The migraine that one gets around menstruation tends to be migraine without aura, even if you would normally get one with aura. And it's often quite difficult to treat and more severe than at any other time of the month. How can you treat it? Well, it depends very much whether the woman has a regular menstrual cycle or whether she has irregular periods. Because if it's regular, then you can institute certain treatment regimens, and they would start 2 days before the planned onset of her period. And you carry on with this treatment every day for up to 5 to 7 days, in fact. So you're trying to cover that dip in the estrogen. And so you can either use non-steroidal anti-inflammatory drugs. So you can use naproxen, which you can use any other month as well, but you'd use it this way in its regular BD regime, or mefenamic acid, which people often use for other menstrual issues as well, such as dysmenorrhea. And yeah, if the non-steroidals don't work, then next thing to try, and it's just like stepwise approach, would be a triptan. And if you're going to use triptan, then the longer acting triptans are better for this. So bromotriptan is the longest acting of the triptans. So you can use 2.5 milligrams BD for 5 to 7 days. But there have been some studies also showing naratriptan and zolmitriptan, although zolmitriptan is much shorter acting, and therefore you'd use a PDS regime for that. If the woman has an irregular menstrual cycle, then mainly it's hormonal manipulation that you're going to be suggesting or recommending. And Anne mentioned one of these options in one of her case scenarios where a woman had menstrual-related migraine and went to tricycle the combined oral contraceptive pill. So as you know, when you take the oral contraceptive pill, you take it for 3 weeks, and you have 1 week off. So this tricycling means instead of having one migraine every month, you will have one every 3 months. You can also use a vaginal ring, or which contains 15 micrograms of estradiol. That can be inserted regularly as well. And then other methods of hormonal manipulation involve changing the pill-free period from 7 days to 4 days. I mentioned the estrogen, but you can also do an estrogen daily patch or gel in the same way that you would use a triptan or a non-steroidal, but of course that would require the woman to have a regular menstrual cycle, so you can predict that. There's some evidence that using desogestrel can be beneficial in women with migraine. There was a meta-analysis of around 200 women suggesting that there's a modest improvement in their migraine in general, not specifically menstrual migraine, on desogestrel. So that's another option, another hormonal option. And then there's less evidence for this, but progesterone depots, they inhibit ovulation. And so if you're inhibiting ovulation, you're reducing that sort of fluctuation in the hormonal milieu. So actually, there's some evidence that that will be also helpful. And then if you get into the extreme levels, you've tried all this, there's gonadotropin releasing hormone analogs, which we inducing a chemical menopause, but that's pretty severe, and you probably want to involve an endocrinologist at that point. Interestingly, we're all using CGR, well, a lot of us using CGRP-related drugs at the moment, and the antagonists are coming back. This is an old antagonist, elcagipant, which unfortunately never came to market because it was associated with hepatotoxicity. But there was a study using that for 7 days to try and see if it would reduce menstrually related migraine. And it didn't meet the primary endpoint, but it did reduce menstrual migraine days. So with the advent of the new CGRP antagonist coming, that would be interesting to see if we can use that in the same way. And then there's a very small open label study looking at vagal nerve stimulation, -3 to 3 days as well, which suggested some benefit. So this is my slightly ectopic slide. It's nothing to do with menstrual migraine or pregnancy, but it is relevant because topiramate is widely used in migraine with women, and it interacts with the contraceptive pill. So for those of us who use topiramate, you need to advise your female patients that it will interact with most of the pills, in fact with all of the oral pills, whether it's progesterone only or combined pill. And the safest method of contraception would be the depot progesterone or the IUCD coil, the Verena coil, and anything else it will interact with. So that's my little ectopic slide. So moving on to pregnancy, this is sort of the section of the graph here that I showed before, showing estrogen going up and then dropping, associated with this postpartum peak. So some women experience a worsening of their pregnancy in the first trimester, and this is partly hormonal and partly due to the fact that they may have morning sickness, maybe vomiting, maybe not sleeping well, but mainly hormonal. And then the good news, however, to tell them is that by the end of the pregnancy, or even by the second trimester, most women improve, and that's probably correlated with the increase in estrogen. Some women develop migraine aura for the first time, and as Anne mentioned, that's to do with the higher levels of estrogen, and that can sometimes alarm people if they've not had aura before. And then this postpartum exacerbation is very common, and mainly due to a drop in estrogen, but also in fact other factors. So those of us who've had babies and children all know that once you've had them, all the classic migraine triggers come into play: lack of sleep, stress, missing meals, you're not eating properly. So all of this has a compounding effect, and therefore it's a pretty rough time for women. So what can you advise? I think the key message here is that there are many things you can offer a woman who is pregnant. It's not just paracetamol. And I think it's important to take a stepwise approach. So very well to start off with paracetamol, and that might be suitable and that might be enough. But in many cases, it's not. And then non-steroidals can be quite helpful. So some of them are better in pregnancy than others. So ibuprofen and naproxen. I wouldn't use indomethacin or diclofenac. But ibuprofen and naproxen are quite safe, relatively safe in the first 2 trimesters. And then after 32 weeks, you would not use a non-steroidal at all because of the closure of the patent ductus arteriosus, and that's influenced by non-steroidal. And triptans, I'll talk a bit more about that in a minute, but that's certainly an option. Giving a woman sumatriptan is certainly an option. Antiemetics, so in migraine in general, it's quite useful to combine a prokinetic antiemetic such as metoclopramide or peridone with a non-steroidal anti-inflammatory drug or with a triptan. And you can do the same in migraine. And of course, a lot of women in the first trimester or even second trimester can still have nausea as part of their pregnancy, which is probably exacerbated by the migraine. So I think that's quite useful to know. Domperidone is probably safe, although there's less safety data. So I put metoclopramide here on my little chart. And then for those of us who have access to greater occipital nerve blocks, that could be a very good measure as well to try. You can use either lidocaine, or we tend to use lidocaine and depomedrone in our centre. But it's actually quite useful, I find, as it gives a woman a few weeks of a break. If it works, that it can then allow the hormonal levels to pick up, and therefore then she gets better anyway. This is the meta-analysis of oral triptan use in pregnancy. And the two largest contributing countries to this are Sweden, on the top, referenced by the football, which is a topical since they were playing yesterday, and Edvard Munch, who's representing the Norwegians, because they, as you can see, contributed like more than 2,000 patients to the study here. And what's useful to note is that it's not just sumatriptan that was used, but the most commonly used drug was sumatriptan. And the good news is that over 4,000 women who have been exposed to triptan use during pregnancy, there's been no associated congenital malformations and no spontaneous abortion increase or prematurity increase. So that's good news. If you're going to be cautious, I think you probably would recommend sumatriptan, since there's larger number of patients who've used sumatriptan than the other triptans, but as you saw in the previous slide, other triptans were also used. It's probably a class effect, but if you just want to be cautious, you stick to sumatriptan. What about preventatives? Some people avoid preventatives in pregnancy completely. I've had women on propranolol and amitriptyline, and I think it's generally they're the safest. Nothing is 100% safe. There are always risks, but it's a risk-benefit ratio thing, isn't it? So propranolol, I think, is fairly safe, and amitriptyline. So the beta blockers and the TCAs are the two groups of drugs that you can use during pregnancy. Obviously, we all know that sodium valproate is absolutely contraindicated in pregnancy due to neural tube defects, but also due to developmental delay later in life. Topiramate is also contraindicated, as are pretty much most of the other oral preventatives. And then our gracious host, Fayaz, published this paper he has one of the largest Botox practices in the country. And his group looked at patients, 45 patients who became pregnant while they were using Botox. And 31 of those patients continued, and there was only one first trimester miscarriage. I think what was interesting, and if you look at the paper, is that patient subsequently went on to get pregnant again, continued to use Botox, and had a sort of safe, healthy delivery, a healthy baby afterwards. It was quite reassuring. And the mean follow-up after birth for this study was 3.5 years. So it's reassuring, but of course numbers are small, it's difficult to know, but I think it's good to have the data. So well done, Fayaz's group. What about CGRP monoclonal antibodies? I hear you scream, because obviously this is the new kid on the block. And there is, I in my practice certainly not recommending women become pregnant while they're taking these. So in fact, that's part of our consent, is that we're saying you shouldn't become pregnant on this, because these are new drugs and there's no safety data on this. So the recommendation is not to be using these during pregnancy. However, this paper was published in Cephalalgia, which shows that 92 women have become pregnant whilst using these. The majority of these were on arenumab. And interestingly, about a quarter of the patients had spontaneous abortions, although the paper emphasizes that only 15 of those were without confounding factors. And there were 2 birth defects, one with aranumab, one with romantuzumab. So we shouldn't be using pregnancy. Maybe in the future we may have more data like with the triptans, but for now we shouldn't. So this is a summary slide. What can you use acutely? Well, you do a stepwise approach. You do paracetamol, non-steroidals, you then move on to a triptan, and you can combine these with one of the antiemetics, preferably one of the prokinetic ones. I put TMS in here because there was a few case reports of women who are pregnant having used TMS, which is transcranial magnetic stimulation, and I suspect other neurostimulation devices are probably also likely to be safe, although of course there aren't sort of publications of that. And then for the preventative group, I would use either propranolol or amitriptyline. Of course, you'd want to try and keep the doses as low as possible. And then you could have the option of a greater occipital nerve block. Acupuncture has also been used and is thought to be safe in pregnancy. And some people use magnesium. So obviously magnesium has been used as a migraine preventative, sort of as a soft migraine preventative. There is evidence that high doses intravenous magnesium sulfate can be associated with fetal bone defects, but there's no evidence that the doses that are used orally in migraine are dangerous. Of course, it's been used quite a while in pregnant women, magnesium by the obstetricians. And then we've got our Botox in italics, and coenzyme Q. There's a little bit of some data using that later in the 3rd trimester, but again, it's sort of a soft drug to use. Then what about lactation? So the key here is what proportion of the drug gets transferred into the milk. And the sort of overall rule is that if it's less than 10%, it's generally thought to be safe. And of course, the lower the proportion, the better. So the other factor to consider is the age of the baby. So if a baby is premature, then their metabolism is not able to deal with many of these drugs, and so you have to be a bit more careful. And an infant after the age of 6 months tends to metabolize these drugs better. So you can use many of the things that you were using pre-pregnancy, so non-steroidals. You can use, I would avoid aspirin because of Ray's syndrome. You can use obviously paracetamol, triptans. Again, I'll show you a little paper about that as well. And domperidone, interestingly, has been used, in fact, to induce lactation in women in general who are breastfeeding, nothing to do with migraine. So as a sort of added benefit of helping the lactation in this group of patients. So preventative-wise, you can go back to using pretty much what you were using before. You can go, obviously, beta blockers and amitriptyline are fine. If you're using a beta blocker, then propranolol is better than atenolol because there's less transfer of the drug into the milk. Candesartan would be avoided if the baby is premature. And I put valproate in brackets here, and the reason I put it in brackets is because you wouldn't want to get pregnant again. And of course, if the woman's breastfeeding, she may not be using contraception, but it is possible to get pregnant. Topiramate can be used as well. You just have to look out for sedation. So again, obviously keeping the doses low. So this was a study published this year, actually looking at 19 women who were breastfeeding and using triptans. And the researchers looked at the 24-hour collection of milk after taking the medication. And you can see this RID is a relative infant dose, which is very small. So most of these triptans have a very low transfer level into the milk. So the only one I would take, the caveat here is that almatriptan and naratriptan, there was only one patient. So obviously that figure is a bit high, and there are individual factors as well, which may result in higher transfer. So I would be cautious with that result. But interestingly, the nasal sumatriptan was also used. And again, as you could see here, 0.4 to 0.7%, which is quite low. And then there was an older paper looking at the subcut version of sumatriptan, which is a slightly higher 3.5%, but again, not massively high, with a range of 0.3 to 6.7%. So I guess if you had an infant who was premature or you were concerned, then you could always express and discard the milk, but it's probably unlikely to be necessary. Finally, moving on to the menopause. As Anne mentioned, this can be challenging because the perimenopausal period, which can go on for years, estrogen levels fluctuate, as you can see here in this blue fluctuating graph here. And you may also see migraine with aura for the first time because, as she mentioned, you can have peaks as well as troughs of estrogen. And what's quite common is that I see women coming into my clinic and in their 40s who've had migraine since they were young, but very well controlled. And then all of a sudden, they start to have very bad migraine in their 40s, and this is because of the perimenopausal hormonal fluctuations. And the good news is that about 2/3 will improve after they've gone through the menopause. If a woman has had a surgical menopause, meaning a hysterectomy and a oophorectomy, then that does not apply. It's probably because your hormonal milieu suddenly changes rather than having time to sort of compensate. And so the question is about HRT. What's going to happen with my migraine with HRT? Can I have HRT? Is it going to get better or worse? Like with many of these things, there's no one answer that fits all. There's a study in Norway which suggests that many women with migraine get worse, but then there are other studies that don't agree with that. And anecdotally, I've seen women who are better on HRT. I think if you are going to use HRT, you need to use the estrogen component needs to be the transdermal version for a number of reasons. One reason is that the estrogen fluctuations are much lower in the transdermal patch than with the other formulations, such as the oral formulation. And then if a woman has an intact uterus, then she will need to be using progestogens as well. And so you can use the IUCD Marina coil or ionized, microionized progesterone. And if a woman can't use HRT, so it's contraindicated or she doesn't want to, then other options that can be helpful in migraine and also some of the perimenopausal symptoms are venlafaxine or escitalopram, clonidine. So what about the stroke risk? Because obviously people are concerned, stroke risk with migraine and HRT, and stroke risk with HRT. Well, if you take the transdermal patch, then there is no increased risk of stroke. So that's in the general population. So it's the oral estrogen component that confers a slightly increased risk of strokes. The transdermal patch does not. So that's a second reason to use a transdermal estrogen patch in a woman with migraine. And I would suggest using a lower dose of estrogen because we know that estrogen correlates with risk of stroke in other studies, not specifically related to HRT, but related to the contraceptive data. And interestingly, HRT is not contraindicated in migraine with aura, women with migraine with aura, whereas the combined oral contraceptive is. So just to summarize there, migraine varies throughout different phases of a woman's life. And this is due to the influence of hormones, in particular estrogen. But it's important to know that there are many good treatment options out there. Thank you.
Well, thank you very much, Shazia. As always, some good information there. I've been writing all the questions, so we'll take it at the end. But thank you very much for your time. And as always, it's a pleasure to listen to you. And one of my colleagues was particularly praising you. She came and she said, "Oh, I went to ABN meeting last year, and there was somebody, I don't remember the name, was talking about women and migraine." And I said, "It can't be anybody else apart from Shazia."
That's very kind.
Thank you very much. So the next one we have is from the primary care perspective. As you know, that we have been covering both secondary and primary care perspective. And obviously headache is one of the commonest symptoms that patients consult to the general practitioner. And obviously if migraine is 3 times more common in women, there will be more consultation in the primary care. How does a primary care practitioner deals with it? Those without special interest in headache. So we have got a general practitioner here with special interest in headache, who probably has worked all her life working with headache patients, particularly with women. We got Manuela Fontebasso. She's a retired GP, but continues to have a clinical interest in seeing patients with headache. She's an educational facilitator and also an author of the book Migraine and Other Headaches. Manuela obviously have been associated with British Association for the Study of Headache, and many times she has been in Hull giving a talk on the BASH meeting. So Manuela, you're going to talk about primary care perspective. Thanks for coming.
Thank you, Fayez. Just let me share my screen with you. There we go. Sorry about this.
It's okay, don't worry.
Right, as Fayez has said, my background was a GP, and I became involved in the headache world in 1997. And when Fayez gave me this title, it was about the challenge in primary care. And I had to think long and hard about the best way of trying to reflect on this. It occurred to me that actually reflecting on my own story, can you hear me?
Yeah, we can hear you.
Reflecting on my own story about when I started with very little experience about headache, but had an interest in women's health, and then became increasingly interested in headache as a topic, became a clinical assistant and then GP with special interest in headache at York Hospital. Was fortunate to work with a specialist headache nurse, a clinical psychologist, physiotherapist, and a consultant who had an interest in headache as well. And it occurred to me that every single primary care physician has to rise to their own challenge in managing headache and women's health, because we each have different challenges that we need to address. We each need to find different ways of moving forward. And in many ways in primary care, the challenge is about time. 10 to 15 minute consultations, making a headache diagnosis, assessing the patient is always difficult. And I often found that I was bringing patient backs for a series of consultations so I could build up the picture. Working in secondary care, I could have a much more extended appointment. And that was one of the big challenges, really, to accept that you needed to spend time with individuals one-to-one to actually engage them and help them understand. I also needed the knowledge and skills to fully assess the headache, to understand the headache profile, and to work with the patient to find a way to move forward. And then the big thing about women's health and headache was, what was the evidence base for a lot of the things that we were doing as standard practice? And the one advantage I have was that I knew Anne McGregor, and Anne was always available at the end of an email to give me advice and support if I needed it. There was a local gynecology registrar who was also had an interest in the menopause and was able to provide advice. And so I knew where to go looking for information, and I knew who to speak to for advice and guidance. And I think that's the important thing, is to work out what there is local to you that can provide you with the support that you need to grasp the nettle and to expand your knowledge and skill base. And then you needed to become confident in your knowledge and skills, in your assessment and your understanding of what headache and women's health means to the individual. I think the one thing I realized very quickly is that every single person you see is different, and that every single person that I saw and assessed and managed needs an individualized approach, because what works well for one person does not necessarily work for the next person. And you need to work out what was right for that individual. And then managing patients and understanding things is all about managing to convey the risk versus the benefit. And the one thing I was always focused on was the importance of independent decision-making and informed decision-making for the patient. And that meant sharing the right information with that individual to help them make the decision that was right for them. So you give them the options, you help them to look at the risk and the benefit and make those choices and decisions. Now, bearing in mind, I came into the headache world in 1997, but had been established a GP for some time. And there are a lot of contraceptive choices. There are very many different options. And over time, by the end of my GP life, there was still an increasing number of choices that you need to try and pick your way through. There was a greater understanding about the impact of different progestogens and the fact that different progestogens carry different risks and benefits, both for the individual and from the migraine sufferer. There's no doubt that estrogen dosing with regards to contraception has got significantly less, and Shazia's alluded to that about the change in oral contraceptive and the fact that lower dose drugs are used now. And then individual risk factors, and I can remember doing a session for FIRES at the whole BASH meeting, looking at the balance of risk with migraine with aura and how different risk factors impact into that and what those potential risk factors are. I think as a GP, it's important to recognise that despite the evidence, despite the guidance, the patient has the individual right to make a choice. And your responsibility as the clinician is to provide them with the information they need, to engage with them on a wide-ranging discussion, and to share the information and resources. And I certainly found it useful many years ago to use Anne's publication for the Faculty of Family Planning and Healthcare, looking at contraceptive choices, pregnancy and breastfeeding treatment choices, and HRT choices. And what I would do is print out those research papers and encourage the patient to go away, to have a read, and then come back to see me with their questions. And we would talk through what their potential options are and agree what they felt was right for them. Now, we've talked about HRT, and when I first became a GP, HRT was the best thing since sliced bread, and women had it readily available. And in 2002, it suddenly became the devil. And the conclusion of the WHI study was the overall risk exceeds the benefit of combined HRT. Well, I was one of those GPs that actually read that paper, had a conversation with patients, and still continued to prescribe HRT for those people who felt it was right for them. And at the end of the day, it comes back to that individual right of choice, their ability to balance the risk and benefit for them. Because at the end of the day, menopausal symptoms are often quality of life restricting, have a significant impact on them. And it was quite important to understand that. And then managing HRT, I used HRT a lot to manage perimenopausal migraine and postmenopausal migraine, and developed strategies that helped me manage that. In 2013, a study was published that stated the menopause hormone therapy has a complex pattern of risk and benefits. No surprise there. It's a complex process. It's down to the individual. You have to assess individual risk and personal choices. And then we had the NICE guidance published in November 2015, which then emphasised the fact that every woman should be offered the opportunity to consider HRT, that we should use topical agents, the patch or gel. And I have to say, I always used the patch or gel when managing patients with HRT, for HRT, particularly with migraine, because some patients were very, very, very estrogen sensitive. And I would often use a quarter of a 25 microgram patch, fitted the patient with a Mirena coil, and then titrated up the estrogen dose very slowly until I got a balance of menopause symptom control and migraine headache control. And that took time, effort, and energy. But the most important thing for me was the fact that the patient really valued the time and effort it took to establish the right balance of treatment, and the fact that they got good symptom control. SHAZIA has mentioned pregnancy and breastfeeding, and there's never going to be gold standard double-blind placebo-controlled trials. So what we have to consider is the data that's available, is what has been published. And SHAZIA has talked about the triptan use in pregnancy, triptan use whilst breastfeeding. And again, I would encourage patients to read Anne's paper that was available at the time. Many of these patients were long-standing migraine sufferers, were happy in their use of triptans, and it was always a balance of risk. And I did have several patients who chose to take sumatriptan through their pregnancy. I think it's important to look at whatever review publications there are out there that explore the published data, explore the range of evidence, and support any decision-making that you have. And there is expert experience and knowledge, and I was very fortunate to be able to talk to people that were able to support me in my decision making. I think then it's the question of sharing information and resources with the patient. I emphasize the importance of informed decision making. It's about discussing the balance of risk and benefit for that individual. And at the end of the day, whatever decision they make is personal choice. So in conclusion, choices and decisions are never easy. Decision making is extremely complex. Building knowledge and skill takes time, and it certainly took me many years to increase in my knowledge and skill, increasing my confidence levels, to develop that rapport, work within a team, work with the patient. It takes time to collate the resources that you can use, but once you've got those cohort of resources, there is always a reward, because you can share that patient with that information with the patient. You can work with them through their journey to take back control of their migraine headache and their symptoms. And at the end of the day, the patient will make a decision that's right for them, but they can only make the right decision for them if they are adequately informed. Thank you for your attention.
Well, thank you very much. Thanks very much, Manuela. I noticed you haven't shared your slides.
Did I do my slides, my presentation?
No, I think we heard you.
Oh, right. Oh, I'm really sorry. I don't know what went wrong there.
Yeah, I don't know, because I sent you a message as well. But anyway, that's okay. I think, was there anything in the slides that we need to see, and you can share it?
I'm quite happy to share a PDF.
Well, that would be good. Yeah. I thought it was intentional. Otherwise, I would have interrupted.
No, I saw it on my screen.
Right. Anyway, right. So let's take the question. Let's welcome back Shazia. There you are. Good.
Hi.
Okay. There are a few live questions which I have said that we would take it live, and then there are some other questions. Let me start with one of my questions about tricyclic combined oral contraceptive pills. Would that be okay even if the patient has migraine with aura?
So the migraine with aura patients it's now contraindicated for a woman with migraine with aura to have a combined contraceptive pill. I mean, that's a whole other talk really that we can have about that. But that's the guidelines have been set because of historical data suggesting an increased risk of stroke with migraine with aura. And particularly those who are using the contraceptive pill with estrogen, although it is clearly an estrogen dose-dependent effect. So currently, we are not recommended to be using combined oral contraceptive pill in women with migraine.
But I think the slide probably give a message that when you're using the tricyclic combined oral contraceptive pill, that is, you could do it in both. But
sorry, I probably should have clarified that.
The other thing is sumatriptan. I know it's safe in pregnancy. Is other triptans exactly the same? I know that the data is for sumatriptan. But
yeah, so in that table I can show you again. There were different triptans used in those studies, but the most commonly used triptan was sumatriptan. So other triptans were used as well. Pretty much all of the standard ones were used. And you can, I guess if you wanted to, you could look up the data of how many numbers in each of those, but most commonly used was sumatriptan. So it's probably a class effect that they're safe, but if you want to be extra cautious, just use sumatriptan.
I thought the second one was naratriptan. There was suma. And
there's a few of them. I can bring up that slide again, but there's a few. It's not just, there's elatriptan as well. I think the zolmitriptan was certainly used as well. Didn't see much of the longer acting protriptan, but then we never really used that.
In the same continuum, codeine in pregnancy, if they can't take the non-steroidal, and if they can't take the paracetamol, or if they're not responsive to triptan, what about codeine in pregnancy? How safe is that?
I mean, it's used, I guess, again, it could be associated with sedation and things like that. But I think in cases where nothing else is possible, then you can use that, obviously using a lower dose if possible.
Is it relatively safe?
Yeah, I think it is. Obviously, like any opiate, you have to be careful with, neonatal, if you're coming up to the 3rd trimester, particularly, then you'd have concerns about things like neonatal sedation. But using a low dose infrequently would be probably relatively safe.
Thank you. One live question, Manuela, was about riboflavin. I know the riboflavin magnesium coenzyme, they all have got just a single RCT. But how would you think riboflavin magnesium combination is usually available as Dolovent or riboflavin alone? Do you think that has an effect in pregnancy?
I'm not aware of any evidence either way. I've not seen any research looking at the use of that during pregnancy. So I can't specifically ask that. I've sort of looked at the research and published evidence using those drugs as prophylactic agents, but I've not looked at them using them in pregnancy specifically, I have to say.
Right. What's your view about it, Shazia?
So the problem with the riboflavin is that the doses used in migraine are supramaximal. So a low dose sort of normal vitamin tablet dose would be safe, but there isn't any safety data on the supramaximal doses. So I think you probably have to be a bit cautious about that because of the very high doses that are used, which are like 4 to 8 times higher. It's much higher than a normal dose.
Is it 400 milligrams?
400 milligrams is very high, so it's not a standard dose like you'd get in a vitamin tablet. So the low doses are safe, the vitamin tablet type doses are safe, but there isn't any data looking at such high doses in pregnancy.
So better to avoid.
Yes.
Okay, Manuela, I know in primary care, particularly those people like you who have got expertise in headache, use preventive treatment following the NICE guidelines. There is a big problem that candesartan is not recommended in the NICE guidelines. It is recommended by BASH, it's recommended by SIGN guidelines, and I get lots of letters saying you have to prescribe candesartan, and I usually go ahead of topiramate. I use topiramate after candesartan, beta blocker, amitriptyline fails. How you deal with that issue in primary care?
I think as a GP, without the experience and expertise, I think it's quite difficult to take on board a decision about prescribing something that you have no direct experience with. I think there is certainly good evidence to show that candesartan has a part to play. A lot of the GPs, especially that I know, certainly use candesartan in their clinical practice. And I think the disadvantage of it not appearing in guidelines is that GPs are less confident about using it in general clinical practice in primary care, because it's that need to have that confidence backing them up, that it's part of a guideline, it's part of NICE, it forms the backbone of clinical practice, and I think it's very much a question of having, if you're going to recommend it, then as a GP I would probably have a conversation with the doctor that was recommending it, and reassure myself that it was okay, and perhaps look up the evidence base for it, and use that to base my decision.
But would you agree that you use candesartan ahead of topiramate?
I think as a GP, the profile of patients that you see is quite different to the patients that you see in secondary care. And so the point at which, as a GP, I would find that patients responded much more to things like beta blockers, because you were seeing a different cohort of patients. As you see patients in secondary care, it's almost the sort of the top of the iceberg, and so they are much more complex patients. They're much more challenging to manage, and so you're on to the slightly more complex drugs in terms of making choices and decisions about which is the most appropriate agent to use. And I think that's the difference, is the patients you see in primary care with headache, migraine, frequent migraine is very different to the cohort of patients that you see in a secondary care setting. And so their prophylaxis needs are very different. And so as a GP, I'd be much more likely to prescribe beta blockers, or perhaps someone with frequent migraine, lots of neck pain and soreness and stiffness, and consider a low dose tricyclic than I would thinking of candesartan as a second or third line agent.
No. Well, my question was that amitriptyline beta blocker, no doubt they are the first line. When it comes to after beta blocker and amitriptyline, would you consider candesartan ahead of topiramate in women, not necessarily pregnant or something?
Yes. I mean, the answer to that is yes, because of the risks of the problems of topiramate and women becoming pregnant, and the importance of making sure they're on reliable contraception if you're going to, in terms of the risk benefit of considering something like topiramate. But it depends on their response to candesartan, and then it's the decision about where you go next.
Okay, so I've got a question from Sarah Miller from the National. She says that a lot of women complain of mid-cycle pain, which is the ovulation pain. Is it a random chance, or is that a drop in estrogen that causes that pain? So, Shazia?
Hi, thanks. Can you hear me? Because I'm having a few issues with my Wi-Fi. So everything keeps freezing for me. Yeah, that's a very interesting question. I used to think that was a thing as well, but there doesn't seem to be as much evidence for that. In fact, Anne McGregor did a study on a small number of patients quite a long time ago, looking at that to see whether there was any evidence that ovulation induced migraine. Didn't suggest it. However, I get patients who say that too, and you could postulate that the drop of estrogen is relevant there. The reason that was postulated that ovulation doesn't cause.
We lost you, Shazia.
Cause migraine is finding of the eye. Can you hear me?
We lost you for 10 seconds, so maybe.
Can you hear me?
We can hear you now. Yeah.
Okay. Sorry.
Give that answer again. Sorry.
Joys of technology. Yeah. So I said so there isn't evidence as much as there is for menstrual migraine. And Anne McGregor looked at this a long time ago, looking at a small number of patients where they looked at the estrogen levels and whether they had migraine in different phases, and they didn't find, I think, with the ovulation so much. But I do see patients who have that, and it could be to do with the drop of estrogen, but it's thought that the system has to be primed before the estrogen drops in order for there to be migraine. If you look at the little graph that I showed, interestingly, oxytocin doesn't so much at ovulation, it drops just before menstruation. So you could argue that that's why ovulation isn't so much of a trigger, if it is more actually related to oxytocin. But yeah, I have seen one or two people who do also feel that it is ovulation that triggers in them, but not very, very much less common.
Okay, there is just one live question, and I want to take both of your views, starting with Manuela. Melatonin in menstrual migraine. I've never used it, so I've never used it. Have you, any of you? So start with Manuela.
I've never used it, and have no experience of it on that basis.
I haven't used it either, but I did recall seeing something about melatonin fluctuations, and the melatonin is lower around menstruation, and therefore would be interesting to see and do a study actually if it does work, because obviously there is evidence that it can work in migraine. It's not great evidence, but I do occasionally use 3 melatonin in women, in anyone with migraine, not necessarily women. But yeah, I think it will be interesting to see whether it does work. I haven't done it specifically for that.
I thought that was a very interesting question. I think this comes from some lady from Iran, one of the headache specialists in Iran. Kay Kennis from Bradford asking a question. We start with you, Shazia. Is there any evidence about whether vaginal ring causes less migraine in hormone-free interval compared to the combined oral contraceptive pill? And can we tricycle the vaginal ring or use it continuously like combined oral contraceptive pill?
I'm not aware of any evidence comparing that. The only sort of what I've read about the vaginal ring is it tends to be used more of a sort of stopgap to cover that period where the estrogen level is low, rather than using it back to back. So I'm not familiar with that as a use of the vaginal ring. I'm not sure if Manuela, if you're familiar with that.
No, I've not had any experience of using it, and I've not seen any recent sort of evidence about its use. So I can't comment more than that, I'm afraid. I can see the logic of it, using it in the pill-free week, because of stopping that fall of estrogen levels in much the same way as you might use the estrogen gel. But I've no personal experience of using the vaginal ring itself.
Right. Okay. One question that I was going to ask you, SHAZIA. I'm quite nervous prescribing CGRP monoclonal antibodies in young females, particularly those who haven't completed their family. Now, with the Botox, obviously, we started them. There was some evidence from the Elegant study that it was relatively safe, and we gave the choice to the patient whether they want to continue or stop. But I'm inclined to ask the patient to really practice contraception if they are going to go on the CGRP monoclonal antibody. What are your views about it?
Yes, I completely agree with that. And in fact, in our practice, we get to find a consent form, and part of that consent is that they should not be getting pregnant on it. So we discuss that with them quite actively when they first come to clinic. With our practice, we see all our patients for the first injection, and that's part of the process. Because I agree, I think particularly given that paper showing 1 in 4 women having had spontaneous abortions, I am quite concerned about it. And what we advise them is, if they are planning on becoming pregnant, they should be off it for at least 3 months.
And have you got anybody who got pregnant on CGRP monoclonal antibody?
I had one patient, and they did have a spontaneous abortion.
Oh, they did?
Wow. But they did have a history of having had abortions as well. Yeah. But even still.
Yeah, I only started to prescribe in the last 6 months, so we haven't had anybody. But I remember with Botox, in spite of saying don't get pregnant, a lot of them got pregnant. Yeah. I want to continue. I don't want to stop. Manuela, just one question about transdermal estrogen better than oral estrogen or oral HRT. Why is that?
My understanding is that NICE looked at the evidence base and demonstrated that transdermal estrogens don't carry any increase in risk to the patient, specifically with regards to breast cancer. I think for me, in supporting women who have significant perimenopausal symptoms, I found them to be quite estrogen sensitive, and what you're trying to avoid is the peaks and troughs that you get with oral medication by using a transdermal option. That fitting a Mirena coil gives you endometrial protection, and I found that by using a transdermal patch, particularly the matrix patches, you could cut them up and slowly titrate up the dose. So for me, it was purely experience. It was after conversations with Anne about the best way to manage things and trying to find a way to support individual patients in getting control of their symptoms without giving them too much estrogen that seemed to trigger a sort of reaction with regards to increasingly frequent migraine headaches. And I just found that it gave them better symptom control once you titrated up to a dose that didn't aggravate their migraine of their menopausal symptoms, and it gave you an opportunity to optimize that balance of benefit.
Your view, SHAZIA?
Yeah, I think the other important thing is there's a study in stroke, I think it was Canonico et al., showing that there is no increased risk of stroke with the transdermal patch, whereas there is a slight increased risk with the oral formulation of HRT. So from my perspective, I think that's very important, given this whole thing about migraines having an increased risk of stroke. And of course, what Manuela was talking about with the sort of constant levels, the levels being more constant. And we know that the fluctuations of estrogen are what trigger migraine. That's also why sort of symptomatically it's more useful and more relevant.
You both agree that that's the fluctuation which actually put them at a
high. Fluctuations, but also I think that the risk, the fact that there's no risk of stroke is very important.
Okay, one question came live from about the CGRP monoclonal antibody interaction with the hormonal contraceptives.
Oh, okay. As far as I'm aware, I'm not aware of any interaction. I'm not aware of any interaction between that and the hormone contraceptive.
Yeah, I've not seen anything either. Manuela,
No.
I was just going to hit Google actually. No, I'm not aware of any interactions. But I would be quite happy to go and search and see if there's been any documented, but I'm not aware of any.
Yeah, neither do I. It was a very good question. I mean, you know, has
Yeah.
anybody? I don't think anybody looked at it either.
It's not on their information sheet when they.
No,
You know.
quite.
Right. I've got one question from somebody called LR, and I hope that might be Louise Rusk from Ireland. A 46-year-old lady with migraine that start with the period and go on for 15 to 16 days. And if she has a 4-week cycle, she get 2-week headache free. And if she get a 6-week cycle, she get 4-week headache free. Intolerant of 4 common prophylactics. And I don't know which one they have tried, but the question is, should she go for Botox or CGRP?
Yeah, I mean, I would say yes. So she meets criteria, doesn't she? She's failed 4 preventatives. It's not purely menstrual migraine if it's going on for 2 weeks. So that's the other thing to say, is that it may be a menstrual exacerbation. But even in patients that we have chronic migraine and have headache every day, they can have a menstrual exacerbation as well, but tends to be around the time of the period. So I would certainly say yes, either CGRP monoclonal antibodies or Botox would be suitable for that patient.
Manuela?
I mean, yes, it's my question is the headache the same every day? Is it a chronic sort of headache that's unresponsive to treatment? Is it just a sort of headache recurrence? And just to clarify the exact picture of the headache, but yes, that number of headache days justifies looking at another approach to managing it, and Botox or CGRP antibodies would be the way forward.
Because I thought about that, if it's a 6-week cycle and 4 weeks headache free, then it might not be chronic migraine. And so depending on how many cycles she gets, that kind of thing. But CGRP certainly would be indicated in that case. I think between the lines, I thought the question was that as you give triptan twice a day, like frovatriptan twice a day for 3 to 5 days in menstrual migraine, if somebody's menstrual migraine is about 10 to 15 days in a month, would you go for 10 to 15 days of twice a day frovatriptan?
Well, I think you might get a rebound then, don't you? I don't know.
I would have to say that I would be tempted to try naproxen 500 milligrams BD with a low dose tricyclic and see what headache response you get.
Yeah, no, I mean, I agree with you. I wouldn't give triptan daily for 10 to 15 days, but I thought that might be the question that they were asking. One question to you, Shazia. I was going to ask you, when you mentioned about that if HRTs are not indicated in the in menopausal, you said that you could try venlafaxine, escitalopram, and clonidine. Is that particularly specifically these 3 drugs, or you could use amitriptyline, propranolol, topiramate, and others? I think Shazia got frozen at the moment, so I'll take Manuela for the question, and by that time Shazia will come back.
I mean, I think there is some evidence to suggest that using venlafaxine for menopausal symptoms is of benefit. I have not used clonidine personally, because I've not been in a situation where that's become necessary. Shazia, what are your thoughts?
Shazia, have you? I think she's frozen.
Frozen.
She's frozen again. Let me see. There is another live question.
Can you hear me now? I'm sorry.
Oh yes. Did you miss the question?
I missed the last couple of minutes. My internet connection seems to have become unstable.
I think the question was,
Somehow.
it was my question that you mentioned that if the HRTs cannot be taken, you give them venlafaxine, citalopram, and clonidine. Why these three? Why
Yeah.
not the blocker, amitriptyline, topiramate, candesartan?
Because there's some evidence that they have beneficial effects for the menopausal symptoms as well as for migraine. Although the evidence for migraine in some of them is quite soft, there are, some studies. That's why they're chosen.
I mean, I haven't come across any evidence that these are better than the other. Would you send me a reference, please? Because
yeah, there's a venlafaxine, and there's a paper on venlafaxine, and there's one on escitalopram. Clonidine, I'm not sure I would use either. That was taken as that was a reference from Anne's paper, the clonidine one, actually. Anne may have one.
Okay, one more question from the audience. Is there any relationship with migraines in women and the side effect of COVID vaccine? I see a lot of COVID vaccine headache these days. Is there any?
I think there's migraine in everyone with the COVID vaccine, rather than migraine with women, isn't there? Anyone who touches the vaccine seems to have a migraine. I don't think there's any specific thing to do with women.
I didn't think that either, Manuela, because I've seen lots of people coming with a COVID vaccine who have had Botox, and they say this time it hasn't worked. Anything you could recall? Oh, I had COVID vaccine, and then 2 weeks of continuous headache. Are you seeing quite a lot of COVID vaccine-induced headaches in everyone? Shazia?
Yes. Yeah. Yes. Yeah, I think it's quite common, isn't it? But it's not specifically women.
Right. Okay. I think we have covered everything. Okay. There is one more question just arrived. Is there any association of migraine in patients with head injuries?
Well, that's post-traumatic migraine or post-traumatic headache. Yes. So that's a separate sort of IHS criteria, isn't there, for post-traumatic headache? But yes, you can have a migraine phenotype in patients who haven't had migraine before, certainly.
I think there will be a webinar in about 4 to 6 months, post-traumatic headache. It's a separate topic for a full webinar because there are different perspectives as such. So I think that was all the questions. So I would like to, let me just see what I have done. So I would like to thank, firstly, Anne McGregor, and wishing her mother good luck with the speedy recovery. Shazia, for your precious time. And as always, you always oblige. I've never asked you and you've never refused to talk in any webinar. And so is Manuela. I can rely on these three ladies always in the Hull meeting that you've obliged me. So thank you very much, ladies. That was really good. And for the audience, I just like to show you the BASH YouTube channel. I think I had it in there, but I think I've lost it somewhere. So never mind. So if you Google BASH Education UK, you'll see the BASH YouTube channel. If you want to subscribe it, fine. If you want to see it live, all those webinars are available, and this webinar would be available in a month from now. So thank you very much, all of you, for attending. And again, once again, ladies, thank you very much. So have a nice evening, and thank you very much, and goodbye.
Thanks for inviting me, guys.
Thanks very much.